experts together on different fields and areas of rural medicine, so we can talk about some training issues that would occur or that might occur, or questions that you have about training issues in rural North Dakota that can hopefully help you as educators when you're out there on CMND trucks that might give a better chance to do some good education. So today we have with us Dr. Ben Roller, and you've already met Dr. Jeff Sather, Mr. Ken Reed, and Dr. Randy Slayback. And I'll have them start with Dr. Roller and just describe who they are, what they do a little bit, and then we've got some questions, and then we'll open up for questions for you folks too.
Testing. Can you hear? Is it on? Okay, very good. I'm Ben Roller. I'm originally from New England, North Dakota. I grew up on a farm there, and subsequently went to the University of North Dakota Medical School, and then did a residency in emergency medicine at Hennepin County Medical Center. And I've been in North Dakota ever since then. I was at Fargo for 5 years, and basically Essentia, and then moved to St. Vincent's Hospital in Bismarck, and have been there ever since. I'm the medical director for multiple ambulance services, as well as the medical director of the emergency department. And so my testimony will be based on that experience of working in the emergency department and working with ambulance crews. And I've been involved at the state level too, from the State Medical Directors Society, and know the difficulties that have been experienced over the years with regard to educators such as yourself, and as well as funding at the EMS department, and issues dealing with the basic squads out there, and the difficulties that they've had over the last how many years, but more intensely in the last 5 years with regard to recruiting and maintaining people on their squads. So I'm privy to that, but yet at the same time that I look at this program here to be a tremendous asset for helping the individual squads, helping you as instructors, helping the EMS department of just improving the quality of EMS in North Dakota, and for that matter, the quality of the emergency patients that we get, so that we can facilitate better management and care of those patients when they come into the emergency department. So that's who I am. I'll pass it on.
Hi, Jeff Sather. Was a former paramedic, and I'm from Belleville, North Dakota originally, so I'm a native of the state. And med school here at UND, and then I did emergency medicine residency in Mercy Health Systems in Toledo, Ohio. And then after that, moved back to North Dakota. I've experienced as a paramedic in Washington State too, lived out there for quite a few years in the earlier 80s. And I'm a ER physician, and I'm a medical director. Much like Ben, we have similar background, medical director of the ER in Minot, as well as about half of my job's administrative. I don't work about half-time in the ER. And then also I'm involved with ambulance services. I'm medical director for several in our region, as well as work with flight. And on the state level, sit on several committees and trauma committee, as well as some of the other systems of care committees like stroke and STEMI. And I think one of my passions is getting a bar set for all of our rural areas. It shouldn't matter if I'm in middle of nowhere in the Badlands. There should be a standard of care that I can expect for care. And I think, so that's where my passion is, in developing systems for the state and trying to set that level. And this tool that you guys are going to partake in, I agree with Ben, is probably the most exciting thing to come along, and we're trying to attain that throughout our state. We can put the systems in place, but then you guys can go out and teach those systems. So I also, though, work in have a lot of experience. I work with Ken, or have for quite a while, in rugby. So I see it from both ends. So I've worked in a couple of small facilities in the state as well. And as a physician, and I think going out and teaching that, I know everybody in here comes from a bigger facility. My mindset as a physician is totally different than what I do when I'm in the ER in rugby versus the ER in Minot. When I see a STEMI patient in rugby, it's that patient's out of here. When I see that STEMI patient in the ER in Minot, to the cath lab. So you actually have to think all those scenarios through to end point. So, and that's different. Even though you're the same person, it's different in different situations. So that's the thing that, as instructors, we have to learn.
Hi, my name is Ken Reed. I'm the Director of EMS for Rugby EMS, which is in, obviously, Rugby, North Dakota. I've been a paramedic for 40 years, worked primarily in California most of that time, and some of the urban hellholes.
Hence you're in Rugby, North Dakota.
I also serve as the educational representative to the North Dakota EMS Association. I think this project is vitally important when you look statistically at the state, at the average rural ambulance service and at the average critical access hospital. You're talking EMTs that see themselves less than 25 patients per year and average one critical patient every 2 years in terms of exposure. And emergency nurses who work in emergency departments that typically see less than 200 patients per year. And oftentimes those nurses see less than one critical patient every 6 months. And when we graduate people from these programs, especially on the EMS side, they typically graduate and are placed into service with no patient exposure. And so therefore the things they've learned in the classroom and the simulation lab that can be created within the garage of the ambulance service has not prepared them for the actual patient experience. And so they are often many years into their process before they even see the things that we've tried to teach them. And simulation training is going to offer a very effective way for them to start being able to recognize some of the critical aspects of a patient evaluation, what those skin sizes look like, what those lung sounds sound like, how the patients are likely to react that cannot be provided through any other than through direct patient care exposure, and that's just not being provided for them. And I think that this program, especially with the dispersal throughout all of the state, is going to make a big impact on better preparing them to see things, learn them, and make their mistakes before they actually get on the ambulance run.
Hi, I'm Randy Slavik. I actually work for the university, but I'm the trauma medical director and the critical care medical director for surgery at All True Hospital. My background is I was educated in medical school in Detroit. I've practiced in Detroit and Denver, a very large level 2 in Wisconsin, and now here in North Dakota. I sit on a lot of national committees for the American College of Surgeons, including the Rural Trauma Committee and the Rural Surgery Committee. The eyes of the American College of Surgeons are actually upon us because they may very well utilize whatever we do here as a national model in the rural environment to train people, because one of the big problems is deterioration and recollection of skills when you're not seeing things on a frequent basis. And we see that within our state all of the time. So I mean, it's a daunting task, what has to be done, because the repetition is what develops expertise, and none of our sites in the rural environment, or very few at least, are going to have adequate repetition to maintain those skills. So the only way we can really do it is get out there and teach them on a regular and frequent basis, and find ways in between, your trips to some of these sites to refresh their skills. I mean, you do some of those things at the North Dakota Trauma Symposiums, some of the various statewide courses that go on. But this is going to be a fail-safe thing. I mean, this is how we're going to try to educate, our rural providers, not only in EMS, but also within the critical access hospitals. It is something that everyone is struggling with. We have a real, dramatic shortage of providers developing within the state because we have such a phenomenal increase in the number of, encounters, especially in the western portion of the state because of oil development, but it's impacting the entire state and the entire region. So we have a lot of work to do, and you guys are going to be the ones doing it. So it's going to be based upon your capability, to teach these folks that are going to be providing care to potentially you and your family members and friends when you drive around the state, or you walk around the state, you hike, you ride a bike, you ride a horse, you go swimming, you go boating, you go fishing, you go hunting. I mean, a lot of these things don't happen in big towns.
Randy, since you have the microphone, let's talk first about what are some of the most important emergency conditions that you as emergency providers see, and if maybe we could try to make a list of the top 5 emergency conditions that you see in EMS or in the emergency rooms that you think are important for SIMND to be prepared for.
So I think the first one that comes to my mind, and and certainly in the minds of the media, I mean the top 2 are going to be various trauma-related situations, cardiac and cerebral vascular disease incidents. Anything causes a rapid deterioration in someone's condition. Shock. Whether it's from sepsis, volume deficit, whatever it may be. And then I think conditions that affect individuals at the extremes of age put an extra stress and burden upon you. I mean, the number of elderly individuals that you guys and the providers you're going to be training are seeing is multiplying rapidly. And those folks have a lot of pre-existing issues. They're frequently, well, I don't know, in my mind, they're always on Coumadin or Plavix, usually a beta blocker, so they won't get tachycardic. They'll just crash and burn and become hypotensive. They don't oxygenate well. They bleed. They don't have good perception of pain frequently, and yet they deteriorate because of pain and inability to breathe. I think it's, and then just shortage of, encounters for these folks, so that each time they see somebody who's really critically ill, they may not have seen it for years. So, that's going to be one of the big challenges. But at least those conditions, and I actually have a point of view. I think they all look similar. The things that kill people are they don't have airways, they can't breathe, they're not perfusing, etc. And that can be from a multitude of various causes. But the final common pathway for deterioration and death in our population is frequently very similar.
Ken, from your standpoint, running an EMS service, you're out there in the sticks, you're out there in the field with things. Some of the most important things that they may be able to see.
I think what I see that I would like to see us be able to impact with the program, the number one thing is that I think that a great majority of the EMS folks, even the ER folks, don't really appreciate the assessment of respiratory distress and that slide to respiratory failure. That that they've been discussed with them intellectually, but they don't really necessarily understand how to measure a patient's deterioration and their intervention at that level. And I think that through simulation training, we can make a big impact there in terms of them starting out being able to effectively listen, get history, do appropriate physical exam, get initial treatment, and then also be able to recognize that slide that patients go into with respiratory failure and what they can do in terms of intervention for that. The other area that I think probably should be focused on is sepsis, the screening for that. That I think that's probably one of the most underappreciated presentations, and a lack of appreciation on the part of the pre-hospital people about what they even could be doing to recognize and manage that early sepsis that could make a big difference in terms of outcome.
I agree with Ken's principle that it's easy to list 5 conditions. There's certain things that we can make a huge impact in, but a couple areas Ken touched on, and Randy said it well, things cross boundaries. Airway is probably the number one thing that we have to be able to teach. And I just remember when I was a flight paramedic going out, you go out to a small town, and it's not only here, it happened to me when I was in Ohio. You fly out And the patients in severe respiratory distress and all intubation equipment and the drugs are laid out, but no one there wanted to do it. They waited until we got there. And that goes on across the country. So there's a huge impact we can have, and that crosses diseases. It's the other area that crosses diseases and you touched on it, Ken, is the ability to anticipate change and deterioration of the patient. And I know I see on my end, and I'm sure Randy and Ben see the same thing, that the patient that was involved in the rollover, and then I get the phone call, yeah, they were in a rollover, they got ejected, a few hundred feet, they were found laying in the ditch. I think they got knocked out, but they look fine now. But then halfway in transfer, they crash their pressure, and we find out there's a lacerated spleen, positive fast exam, and they get taken right over to the OR. And there's no appreciation for that this was something bad. So mechanism is being very important in trauma patients. I think trauma is one area that we can make a huge impact, at least in my part of the state. We're seeing this incredible incline in trauma and bad trauma. So there's a big thing there. Then there's the systems that we have getting put in place, like the STEMI system of care. It's almost cookbook medicine, but when that happens, you see a STEMI come in. I see a STEMI, every week when I work a few shifts. But when I'm in rugby working, I maybe see one in the year's time I'm there. So if that's the only place I work, and I only cover the ER in that small town a few days a week, I might go 2-3 years, and same with the nurses that I'm working with. So if we've not seen them practice that's one area that we can practice, and practice will improve our skills when the real thing comes. Because we're going to do the same thing, but we have to be able to anticipate, like our scenario this morning, that the patient could crash. Stroke's another area, systems getting put in place. And again, it's kind of cookbook in what you're going to do and what your capabilities are, but then you add in all these being able to recognize what's going to happen with these patients and what should I anticipate. And so that's, I think, one area. Administering blood, there's simple drugs that we use in emergencies that you rarely use in a rural area, that if all of a sudden I have to do an RSI and I've never done one in the last 2 years and I've never practiced it, what's the dose of the etomidate or the Versed that I'm going to use for that? So there's so much that we can really focus on, and it goes beyond, I think, just naming 5 diseases. I think we look at disease process and we can blend that. If you're good at taking care of a trauma patient, you're probably good at taking care of a medical patient to some degree, because some of the things we do crossovers. So that's my basic thoughts on that.
I'll interject something. The airway thing that you've all brought up really brings home to me a memory that I will never forget, and Jeff will remember this. When I was medical director of North Star Critic Care, they flew out towards Sherwood on the road in the winter, where a snowmobile went over the road and got hit by a car. And I think he was like a 16-year-old kid. And the paramedic was there, and you've got your microphone on your collar. He called back to medical control, and so I was talking to him. He says, "Doc, I think this guy's got a tension pneumothorax." "How do you know?" So he described everything, and he says, "Doc, he's going down the tubes. Can I put the needle in?" I said, "Yes, do it." I don't think he'd ever done it before, but he put the needle in, and he was right down by the patient. And whether I'm dreaming or not, I could hear the psh. And he says, "Doc, he's getting pink, we're bringing him in." And it was an airway issue. He didn't have to get something here, but it was something he could do immediately, and it saved that single event saved that person's life. It was, and when I wasn't there, but I was on the end of the phone, and I could hear this happening and hear the excitement of him, and the patient came in and survived and had a normal life. I mean, that's powerful. Dr. Roller.
I don't have too much to add to the list of 5. However, I want to point out that how is it, people ask me, how is it that you were able to manage an emergency department when you're seeing so many patients and all the time, and how do you keep sane? Well, the thing of it is that when you're trained in a residency program, they teach you the top 3 things to do in the order to do them. And so it's not a matter of I'm thinking about that patient. And unfortunately for EMTs, they're still thinking about the person that's down there. Oh, that's John, who's my friend, or John, he's the son of so-and-so, that type of thing, which waylays that thing of top 3 things you're going to do first, which is airway, then breathing, but always make sure the spine is secure. But that's how we maintain our sanity in emergency department. We have that in our head. We're going to do that every time. We're not going to go on to the next step until we've got that first step taken care of. And so everybody else thinks that you're cool and calm, yes, but you're anxious to get things rolling in the fashion that it needs to be done. That's what you guys are going to do for all those EMTs, nurses, and docs, as far as the simulation labs. Potentially they might be involved. And so as a consequence, you guys are really, really important. And I have another thing that's with regard to the next portion of one of these questions here, and that is, what's the best way that how do I see that you are going to be so integral in making this work, is that you have to manage up. Now, what does that mean? And the only reason I know that terminology is because of a video I had to watch for the hospital. And that is, in the past, what's happened is instructors, such as yourselves, and even physicians, will denigrate others that have been involved, such as if the squad safety person or whoever is in charge of training, the training person, has done things a certain way, and then somebody will come to you, as you are the paid instructor to come in, would say, well, they were doing this and this and this and this and this. And as opposed to saying, well, I'm sorry that had to happen, but how can we make this better? What would make this better for you as a EMT and help you to learn better? As opposed to, yeah, I know you've had trouble with that person. We've kind of had some trouble with that person too. That's not managing up. We have to be, you as well as we, have to be positive. You have to be positive so that they can feel good about what they're doing and what their squad is doing. Does that mean they don't make mistakes? Heck no. But yet at the same time, can we somehow get them to be thinking positively and thinking in terms of what can be done to make this better? And you, with the simulation lab, in cooperation with all the people that are involved in this whole organization, will have a tremendous impact on the morale of the EMTs. And that's what we've been hearing from at the state EMT convention, is that the morale is affected significantly, especially in those smaller squads that have to be on call all the dang time, and they can't find anybody. Well, why is that? Well, people that have been on there, that aren't on there, have been managed down. Quite frequently, that's the issue. They've had issues with other squad members or issues with their trainers. And this, I am hopeful, very, very hopeful, that will be a means by which you will have the materials and the resources with this simulation lab to be exposing them to what they need to know in order to help them become better EMTs. And what Dr. Allen was talking about before in terms of communication, it's not about him, it's not about me, it's not about the doctors. Shoot, we're the last ones that it should be about, even though in the past doctors have been terrible as far as managing owners. You know, I'm not good, or I should say, typically ER docs, I'll just speak for myself, and that is that will say something negative to the EMTs about how they've handled things, that, well, you could have done it better if this wasn't done. As opposed to, man, I'm certainly glad that you concentrated on that airway. That was the best thing you could have done for them. And here are some other tips that I would give. Isn't it a little bit better?
Yeah.
And how frequently do I get feedback as a medical director? because of multiple ambulance services, you should hear how we got chewed out when you came to the emergency department. And that's the kind of thing that I have to deal with. We can't have that. that destroys those the small squads out there, well, the large squads too. No one wants to hear that. We want it to be managed up. So that would be a major point in my book, and will be a major point in my next 5 years of doing this.
I think that's a great lead-in. I think what I'd like to do is just put to the rest of the panel up here, let's make it a couple ways. What are some things that are team breakers? What could cause SimND to crash and burn in their ability to go out and teach? And on the other hand, maybe what are some recommendations you have for these teams as they go out and teach emergency medicine?
I think you got to use every situation as a positive, and I can give you some examples. And I think all of you partly have somebody you work with that, you know, there's that one doctor in the ER that is an asshole. No one wants to talk to him. And so what happens to that one doctor is when something's going on that he needs to know about, no one wants to go tell him because, you know, he set himself up for that. When I was in residency, I learned pretty quickly who to rely on. I already knew, you know, because I went to paramedic school and worked as a paramedic. I went to nursing school, and so you make good friends with nurses right away. So when I did my pediatric ICU rotation, and I had some clinical background, of course, before med school, but so some of the things I probably had a little bit of a jump on some of my residency classmates. But when I went there, I remember my first day of coming in, and the pediatric intensivists, you know, we'd met the night before, but came in, and he said, we have a sedation first thing in the morning. And so I got there, and he says, go ahead and figure out what we're going to do. I'm going to get a cup of coffee. I'm like, I mean, figure out what we're going to do. You're not going to help me? So I went to the nurses. I mean, who do you go to? So the nurse said, we got to do a sedation for a TE on this 5-year-old. What does he usually do? You know, so I went to the nurses and talked to them. And I got to be good friends with the nurses, and what a great rotation. And about halfway through my next rotation, the guy that, you know, when you go through residency, at least in our residency, we had a pattern of rotations we did. So there was someone following me through that same pattern. He comes to me and says, this rotation is killing me. I said, what's going on? I get called every hour, every night about stupid crap. I said, really? I never got called when I was on Pete's ICU, you know, unless the kid was really crashing. So I went by the Pete's ICU, and I said to one of the nurses that I got to know pretty well, what's going on? He is the biggest dick we've had through here in a long time. So every time something came up, they were making a note because they knew they could make it miserable for a resident. But in the real world, you see the opposite, that if someone's that dick, you know what? My nurse will come to me and say, hey, you know, I saw this, or you ordered this, is that really what you wanted? Where when it's somebody else, no way, they're not going to go talk to him because it's the answer they're going to get back. So everything's got to be positive. So if the nurse does something, so this is a real world thing, the doctor didn't get informed well on his patient. Patient's supposed to get an IV, supposed to get nitro drip, some things were supposed to happen, and it didn't happen because the nurses were having trouble getting IV started. Well, then when the physician found out what was going on, about 30, 40 minutes later than he probably should have, he blew up at the nurse and started yelling in the ER in front of everybody else. That told the nurse how incompetent she was, and when in reality, the reason he wasn't told was his own fault. Because of his attitude, no one wanted to go talk to him. And so communication has to be positive. When he found that out, that would have been a perfect teaching moment to say, you know, here's what happened in this situation. You know, he should have came to me right away because I would have pulled out the ultrasound machine, or would have helped, would have got somebody else to do this IV. So everything needs to be positive. Even if it's a negative thing that happened, look at the positive side of it. And so the communication should be open, and it should be able to go both ways. So one thing we have to do is check our egos when we go out to teach. You know, if Randy's teaching me about trauma, I'm not a trauma surgeon, and tells me how stupid I was because I didn't do the FAST exam right when I'm coming to ATLS and learning about it, that's not, what that's going to say to me is, what an asshole. I don't want him to be watching over me. But if he says, you know, hey, let me help you with that and show you how to do this differently, and here's some other choices you can make when you do this, or try this different approach, all of a sudden it's positive on my part. So we can't go in as the nurse that works in the big hospital or the paramedic that works at the busy ambulance service or on flight and expect everybody in the room to have your background, because, you know, Ben and I have very similar backgrounds, and we're both ER docs, but we've seen different things through our lifetime, and we'll probably take a different approach in different areas. Doesn't necessarily make his better than mine or mine better than his. What we really want to see is the same outcome. And in medicine, like so many things, there's 100 different ways to do everything. So we need to check our egos, we need to have open communication, and we need to listen to what they're telling us. If you haven't walked in their shoes, you don't know what it's like. And, you know, I've worked in some small facilities, and I tell you what, it feels way different when you're in that facility on that end of the phone. And I call into some of the same people I work with, and in fact, I got mad and hung up on somebody because they didn't know who I was. And I didn't like the way they treated me. And I tell you what, when I called back after I calmed down to talk to him about it, it's like, you can't talk that way. You got to check your attitude sometimes. So we really need to do that. And that is the one thing that would break this system. If we go out and step into somebody else's playground and then start telling them everything they need to do. We're there to reinforce and teach them accepted, evidence-based ways of doing things and improve their care. But we can't go in and say, you have to do it this way. We need to listen to how they do it.
Ken, if you can give us that same kind of viewpoint from your standpoint of being a paramedic, and directing the paramedic and in a small town, then I think what we might do is it might be best to open it up for questions, because I bet there's 101 questions forming out there, and if not, you guys have more too. So Ken.
I think one of the things to realize is as you go to many of these rural facilities and rural ambulance services, that the culture of these organizations often revolve around either a matriarch or a patriarch who runs the place and often sets the tone and goes on every call and runs every call and tells everybody what to do. These are also many of the ones that are crying at conference that they're struggling and they can't get members and everything else. And I think that early on when you start making your contacts, you're going in is to sort of recognize that, because what you find is probably a group of EMTs who are in earnest want to do better, but are often somewhat restricted by the culture or the belief system that's sort of been developed there by whoever's kind of running the place. And it isn't always necessarily the squad leader or someone else. That I know in our areas we have a couple places where the squad leader constantly talks about how they can't get anybody engaged, anybody to take over, and as soon as they get somebody in place, they start running them all over the place. And of course, they obviously don't last in their tenure, and then it falls back to that person. And that's even the same within many of the critical access hospitals, that there is one provider who very much sets the tone for how things run there and how things are handled. And to not recognize that, or to help identify that, or to immediately dismiss that, then you call into question the entire culture of the place. And their motivation then to learn what you're offering may be somewhat diminished. So some of it is kind of getting a lay of the land and figure out what things work, and not quickly dismissing things that they tell you that may be contrary, because that's what's held, in terms of a belief system or a system of care or a standard of care within an organization. So a lot of the changes that we try to make through EMS education are often incremental and frustrating, because you want it all to you want it all to turn on a dime. And just because you have evidence and you have support that everybody should just grab on, but there may be a lot of other factors that make them resistant and less willing to listen to what you have to say, until almost that you can, you have to turn the one before you can turn all of them. And don't be surprised if you encounter that when you go to these services or these small hospitals. Shelley?
Yeah, so let's say you do identify this before you start running any scenarios in there. Is it better to encourage that person then to be the team leader and to run the show? Or is it better to try and encourage them to have a different role? Or how do you best impact that group and that entire team I mean, what's the best when going out there and doing the education if you picked up on that?
My experience is to engage that person initially and create a situation where they feel that their authority, if you will, is not being questioned or put into place, or that they're not being pushed to the side because now you're the subject matter, because this person is often the most experienced person at that squad, and they're the one that, even if they're not on the call for some reason, the one they call on the cell phone and ask them what they should do. And so embracing them, even asking them for input, feedback, giving them the first opportunity to even be the first one on into the scenario or whatever, so that they and then giving them positive feedback and not dragging them down right away, even if even in the worst simulation, no matter how heinous it is, there's at least a couple of things they did right. And so you can focus on those positives and be able to, once they see the value of it, then they're going to kind of give their endorsement to what you're doing with everybody else. Because the worst thing that happens, you come out and spend a whole day training there, and as soon as you drive away, they're like, just ignore what they said. And you don't come back for a year, that person remains the resource, the authority for that particular hospital or ambulance service. So I guess that would be my best tact is that you have to engage them. And there may be some battles here that you don't win. You may hope to change things, but there may be places that are, we look at what's going on with all the programs here. We still have ambulance services that didn't want to take a 12-lead capable monitor. Didn't see any benefit from it, and despite education and everything else. So not everyone is going to openly embrace you. Other people, the majority of the EMS people in a lot of the critical access hospitals in the state are hungry for education, for learning. And now that's even harder for them to get out and get it. We see it from the association standpoint. We used to have a conference with 2,000 people there. Now if we hit 600 or 700, we're doing good. And it's just a factor that there's far less EMTs and far few of them can leave to come to a conference or go into education. So this is going to be very impactful when this can be brought to them.
Sure.
Other questions from the audience?
I just have a couple comments. Number one, I agree 100%. There's truly an art to giving negative feedback. And sometimes it's called the feedback sandwich. And you have to make it impersonal. You can be tough on the problem, but you do not personalize it, because they did not come to do a bad job today. They came to do a good job. So I mean, it's all in your technique. Okay, you cannot sacrifice your standards just to be nice. On the other hand, there's no reason to be nasty when you're just trying to teach them what you think is the right way. And you have to be open-minded and understand where they are coming from. But remember, critical errors with critically ill people always end up costing somebody, and it's usually the patient. So, when they tell you, I don't want to put a chest tube in because it's only a half an hour flight, you may have to disagree with them, but explain to them in a fashion that is not threatening. I mean, people in this state are nice for the most part. It's different if you're in New York State, okay? Then you can just tell them they're wrong, because that's, truly, that is what they are used to. And if you don't tell them in that fashion, they don't understand you. On the other hand, around here, it is emphasized to be nice. And that's fine, because that's whom you are dealing with, is other really nice people. But still, you need to get your point across. Okay? So it is, you do reinforce the positives. You do get buy-in from that experienced person at the facility. Okay? And then you ask for feedback. Well, what do you think? How could you improve this? What could you have done differently? Hey, what about this? Do you think you maybe should have decompressed the chest, before you put them on the helicopter or the fixed wing? What do you think? You can get input and discuss it, okay, in an interactive fashion. That tends to be less threatening. And then they can actually maybe come up with the idea that maybe they could have done it differently. But remember, everybody's coming to this with the right intent. You know, they do want to learn more. And, you know, and don't be overly critical, obviously, but don't let them leaving thinking that, I don't really need to do that. The airway isn't that important. You know, just get them on the ambulance or on the helicopter. Because you will save more lives by doing airway, breathing, and circulation interventions than anything else you're going to be doing.
One of the areas I think that we really can focus on in some of the small facilities is just basic process. And facilities where I remember working in a small hospital in Ohio in a place called Hicksville. That's the name of the town. It was about 40 miles from Fort Wayne, Indiana, right on the border. And I remember doing a chest tube one night. I had a trauma patient come in, and typically, you know, I don't know who covered their ER, but I was out there just doing welcome work and basically moonlighting when I was a resident. And I remember getting the X-ray and wanting a chest tube, and the nurses looked at me like, a chest tube? But we're only 40 miles from Fort Wayne. The helicopter is going to be landing any second. I said, the patient needs a chest tube. And literally it had dust on it.
Yeah.
You know, when they went and dug it out of the basement or wherever it was. So when we're training, one of the things I think that we can really focus on is process. And again, seeing patients that, and we're getting better and better as time goes on, but I think back of patients that I see that are just train wrecks that spent 3 hours laying in a little hospital. And, you know, when I work in the hospital and Ken brings me a patient, and, you know, my focus in trauma is ABCs out the door. And so, do they have an airway? Are they breathing okay? I want a chest x-ray before they go so I know if they have a pneumo. If I have a pneumo, I need to put in a chest tube, and I want a pelvic x-ray, and I do my quick head-to-toe exam, and if there's a pelvic fracture that's open book, I want to put a binder on. That's really my capabilities there. Beyond that, Ken can do most everything else in the ambulance if the patient doesn't need something right away. So really focusing on process, and I think what you tend to see happen is people start down this path of doing things, and they're not thinking the end of the game until the end of the game. And, you know, I always tell people when I talk about things is a physician in a rural facility, one of the first things that comes to my mind is what's the end for this patient for my care. And it's that way even working in a busier ER. When I see is what's going to be the end, and usually about, and you can correct me if I'm wrong, Ben, about 95+% of the time, within 2 or 3 minutes of seeing a patient, I know that they're going to be discharged at some point or they're going to be admitted at some point. And many times I probably know that they either need to go right to the cath lab or right to the OR. You know, it really doesn't take long, and then you've developed a differential and you think this is the problem, and then you do some things maybe to prove it. So in the rural facilities, boy, when you're dealing with STEMI, they should be thinking immediately, what's out the door? Is it thrombolytics within 30 minutes and out the door, or is it primary PCI and out the door as soon as possible? So it's the processes where the little facilities stumble. The nurses are good, the doctors are good, but when they only see one major trauma patient a year, they're missing the simple things, and they're going through all the steps, and they're fumbling a little bit at the steps because they haven't practiced as much as some other people. So really what we need to refine on is their ability to use their tools in the best way they can. You know, we're not going there to say, your monitor's 20 years old, you guys should get a new monitor. I mean, if they ask about equipment, certainly give your advice on equipment. You know, if you go in and say, hey, when we do RSI, our protocol is to give etomidate, this, and this. Well, you go, all I got in my box is Versed. That's what we use. Well, that's their protocol. And if you're doing that with an ambulance service, they have a medical director who's going to have to change that. So you might not even be talking to the people that would change some of the things that you think maybe should be changed. So we need to really work with their tools and teach them to use the tools they have. And then if we can encourage enhancement of those tools. But really, if the plays are all in the playbook, it's helping them organize them the right way, I think, is the biggest way to enhance care in a lot of places.
Any other questions that you have? While you're thinking, I have just one other thing. And we teach medical students and residents that come through the emergency department. And you've got a difficult task as instructors, because when you're teaching something, you can expect them to remember the top 3 things, maybe the top 3 things. Like if I'm talking about Bell's palsy, I can maybe expect them to remember the top 3 things in Bell's palsy. But after that, it's all going to be dribbling off to the side, meaning they're not going to remember that. Now, but the advantage that you have is, with the SimLab, that things can be on videotape, that they can review. Mm-hmm. Holy moly. You may be familiar with Khan Academy, which is a means by which this man by the name of Khan has put on videotape math lessons for his nephews and nieces that now is up to 2,500 to 3,000 different videos, educational videos, mostly on math, and then there's several other ones as now, because this was funded by Gates, Bill Gates, to develop this, and it's free on YouTube video. The same thing can happen with these medical things. And it may take one person seeing the dang video 15 times before, aha, I got it. 1, 2, 3, this is how I'm going to do it every time from now on. Now, we expect them to be shown once or twice, and they to have it, and then they don't see it again for another year. That's not going to work. That's not good. They have to see it over and over again, and some maybe 15, 20 times before they get that aha experience. Now, even you, as you're going through this material, may find that it would be really helpful if you could watch the video on this to capture or get in your mind exactly what you're going to do with it when you're doing the training. We're that way. We're not all the same, and it might take 15 times. And so that's an important part, and that's what I'm really anxious to see in the very near future, and what this SimLab is going to do, and make available to people these videos if they take the time to access them. And a key feature is that they're succinct, which means within a very short period of time that you can see exactly what they're trying to demonstrate. And so I'm hopeful that's going to happen. And I know it's happening already. I'm working on an X-ray program that does that, to teach medical students, residents, on how to read X-rays just by looking, and not talking, nobody else talking to them. And they latch onto that like stink on a skunk. I mean, it is incredible how quickly they learn just by seeing something over and over again. And then it being permanent because it's locked in there. Because they can look at it until their brain captures it. Not when my brain captures it, but when their brain captures it. So I'm excited. I think this is a wonderful thing.
I guess one thing I want to, from my perspective, is you're not going to change the world in your first visit, okay, to an ambulance service or a hospital. There's a couple of things at play here. First off, their adaptation to that technology and that method of presentation, that there's going to be a time for them to become comfortable in that learning environment. And I think the other thing is going to be from your perspective, that I suspect when you get these mannequins and you start programming your scenarios, it's not going to be unlike when people got their first word processor and discovered fonts. That everything had to be used, and so you're going to want to showcase all the different things that your mannequin can do in different ways, and that's a human nature, and it's great because I think it will help showcase the range of what can be presented and taught using these mannequins and stuff. But I think on your visits, probably the plan should be to accomplish a couple of goals rather than, expecting that you're going to hit all of the points, solve all the problems, answer all the questions. and look at this as a continuum of your visits, that each time you're going to build on that. And as you progress, you're going to get better, because I think that, when you first start out with the mannequins, there's still the stumbling and getting everything to work right, and how you interact with it, and the quality of the presentations and stuff. And don't be disappointed. I think that everybody kind of agrees we're in this for the long haul, and we're not sure how far-ranging this can be in well into the future. It's going to depend on funding and stuff, but ultimately this can become a very big tool for us to give these people the experience of interacting with patients and seeing changes in condition or deterioration, and practicing their assessments, and practicing their interventions and seeing the results of those. And it's exciting, but just like everything else, when we first start out, that on the first visit, I don't expect it to be phenomenal necessarily. And from my standpoint, I think that's going to be okay, because I think that the first year or so is going to be kind of a journeyman process where everybody gets good with how you teach with these, because it's really different from what you've been doing with all your other education if you've been involved. And it's a great tool, but also that can also be overwhelming. And don't make your first scenario some complex, rapid deterioration, weird history sort of thing. It's like, they need sort of basic things to get used to it, seeing the process, even working in that environment, and then you can sort of build into it.
A couple things to keep in mind is you end up teaching individuals. So you frequently tailor your teaching techniques to your audience. So when you're dealing with an experienced audience, the teaching points might be different than when you're dealing with neophytes. And similarly, your feedback is frequently different. Who has young children? How do they learn? Yeah, they absorb everything. Okay, they're sponges. Okay? Now, adults are not sponges. Okay, you have to get past, why do I really need to learn this? And who is this who's teaching me? And are they worthy of my time? So in their heads is there's a radio station playing What's in It for Me. So you have to justify why it is important. Now, most of them are already going to know that, and they are eager to learn. But there's different types of learners you're going to encounter, and you handle them differently. I mean, there's the reluctant student, and you're probably going to see a lot of them. There's the know-it-all, and that's frequently the person that has the most knowledge at the facility. So you handle them differently. Some you have to pull out of their shell, others you have to stroke their ego and basically acknowledge that you respect their experience and what they know, and don't threaten them, because that puts up a huge barrier for the rest of the group. The other thing I like to reinforce too, I teach residents on a daily basis, and I've been doing it for years and years, is I can only make this so easy. It's not, we can make it pretty easy for you, but it basically comes down to you having the commitment to learn and to improve yourself. The feedback I give a fifth-year resident is entirely different than what I give an intern. Okay? So, when you have experienced individuals, the feedback may need to be far more detailed and in some ways challenging them versus the neophyte that you really have to support and understand that it isn't always that easy. For you guys it's going to be easy because you already know it. For them sometimes they don't know it. One of my medical school colleagues years and years ago pointed out to the professors, once you know it, it's easy, but until you reach that quote aha moment, you don't. So the techniques that you're going to be utilizing are the best techniques for educating adult learners. When you talk to them, they retain certain things, frequently not enough, but when it's demonstrated and they participate and they can view the videos later, their retention rates are far higher. So, I mean, that's the really beneficial thing. And then the other thing is managing your audience. You know, like I said, you teach to your audience. The different audience types may need for you to change your teaching techniques. My trauma program manager, one of the first things I talked to her about when I came 5 years ago is you need to learn to manage your manager. When you go to them, don't ask for 10 things. Ask for 1 or 2. Write it down, hand it to them, so when you leave, they will remember. Because otherwise, they're not going to retain it all the time, because a lot of times it is new information. So you stress the important things, and they are going to be the essentials. I mean, what do you need to keep them alive, to get them to the next level? And it's frequently, you know, that tourniquet, that airway, that chest tube, you know, or whatever it might be.
Who do you think your most difficult participants are going to be, and why? I guess you don't have to answer that out loud, but just think about it for a minute. And I just got to tell you my personal perspective. In my lifetime, I started in medicine, has taken an advanced first aid course, and I took an EMT course. I went into nursing school. I went back and did paramedic after that, and then I went on to med school. When do you think I felt most comfortable with myself in doing anything to do with medicine? I was most comfortable after I took my advanced first aid course. I thought I could handle anything at that point in time. In my mind, that's what I thought. You know, medicine's pretty damn simple. You know, if you're not breathing, you do this, you breathe for them. You know, if there's no pulse, you do CPR. My depth of knowledge, I didn't know what I didn't know. You know, my depth of knowledge was very shallow. And thinking back, I've said this for years now, I felt way more comfortable after that course than I ever have anywhere else. And I hope my skills are better as a physician than they ever were at that level. But what I've learned going on and doing other things is the more I've learned, the more I realize that my knowledge as a physician, if this room is all the knowledge of medicine, is the size of a sugar cube. I have areas that I think I'm probably an expert. It takes 10,000 hours, by the way, to become an expert. That's why captains of airliners have at least 10,000 hours of flying. That's why medical residencies are at least 10,000 or more hours long. It takes 10,000 hours to become an expert at something. But in journeying to get there, you know, I'm an expert probably in a few things, but when you talk about everything, I know there's a lot of stuff that I don't know about. And I think most physicians realize that. And at the same time, the physician in the group, with all the nurses he works with, is not going to be the one to step forward and say, let me take over and be in charge, because they're going to be afraid of making a mistake in front of all the people that he works with, he or she. And so they're going to be your most difficult audience, I think. And so the approach that you give, I mean, so you're a nurse and a paramedic going out and you're going to be teaching this physician, hopefully as part of the group in the small hospital. They're going to be the hardest nut to crack to really get involved and actually to step up and say things. So the way it's brought out has to be non-threatening and has to be in the format of playing the game as doing what you normally do, and let's just practice the steps and non-threatening. Because that's the person who knows that there's a whole lot of mistakes I can make, and I don't want to look dumb in front of everybody else. John?
I'd maybe like to change the gear a little bit. As I stand back here and look at who we have in front, then I think about what is the biggest area in North Dakota that's calling us, and obviously it's the western part of the state. So we have 2 ER docs from the western part of the state. We have the trauma director of the state and the paramedic who's worked all over the country in that. What can SimND, and first of all, it's going to be mine at Bismarck, but what are those trucks and that SimND group going to be able to, what are they going to be facing out there in the west part of the state? And then what can they help teach the eastern part of the state about what they're learning so we can make that a statewide? So this is for Dr. Roller, Dr. Stafford, all of you really.
I'll say something first because I got this in my hand and I'll give it to Ben. But one of the things that I think we're seeing happening in our area is rapidly changing dynamics. We're seeing, if you look at from the hospital side or the EMS side, there's rapidly changing dynamics. We're seeing EMS crews who used to do limited calls now becoming paid full-time services because of their volume. So there's a big change there. We're seeing paramedics now all of a sudden where there were BLS services because of some of the things that are happening. Some of, when I say things, I mean some of the processes being put in place, like systems of care, and focus on trauma and bigger trauma. We're starting to see some bypass some rural facilities that didn't happen. So we're seeing these ambulance services. I can give you an example. I'm a medical director for Newtown. They're 80 miles away to drive a patient in. So we're seeing paramedics whose training is really focused on, all the critical action things right up front, and then transport that patient. You got the patient for a short time, but all of a sudden we're seeing paramedics that are caring for patients for 2 hours or longer sometimes. So their focus of training has shifted a little bit. And so it's a little harder for them to step back, I think, in some of those roles.
Have they been accepting with those?
Yes. Yeah. And in the hospitals, we're seeing ERs that saw, 2 or 3 patients a day, all of a sudden seeing 20 patients a day. So we're seeing, again, changing dynamics where, it used to be the same nurse seeing, taking care of the few hospital patients, covering the ER, and sometimes the nursing home patients in the same hospital. And now we're seeing some focusing and changes in the way things are done. So those people are hungry for education and training, and they're hungry for help in setting up processes of how to do things, because what used to be a rare event's getting more common, and they're just not comfortable with a lot of those things. None of the small hospitals have residency-trained ER doctors. Most of them don't have a surgeon they can call to come and help out. It's, the family doc who's seeing patients in the clinic, who's, covering the hospital, who's covering the ER, and it goes back to they're looking at this broad picture, but when it comes to some focused things, they're not really comfortable with it. So those dynamics are changing a lot and rapidly in our area. And every day something new comes around that you think, wow, how did this happen, I just think just in the last couple of weeks we've had a handful of deaths in our region. A guy getting in a truck and someone turned on the agitator. Another truck, I don't know what they did, it blew up. But, so we're seeing a lot of deaths, bad injuries, burns, that used to be a rare event that are now almost every day. And they're coming into the small hospitals that almost never took care of these things in the past.
John?
You're seeing a lot more, before the oil boom came, rural North Dakota was, what did we see? As far as hospitals, what we see coming into Fargo, a lot of elderly.
Right.
That's dynamics has got to change.
One area we're seeing a big change. I don't know how Sim would do that, but we're seeing a huge influx of younger people with bad disease that have not had medical care. I bet you in our ER we're diagnosing cancers almost daily on young people. It seems like somebody comes in, 50-year-old guy. No medical care in their life, smoker, driving truck, not sleeping much, and got some problem, and there's a mass in the chest x-ray, and all of a sudden, we're seeing bad diseases, untreated diabetes. And a lot of these people don't want really treatment. They were told that they had to go there by their boss, and all of a sudden, and they don't want you to do much because they don't want anything found, because they don't want to lose their job. I remember asking a guy not long ago, just part of my history, to use any illicit drugs. He says, "And lose my $90,000 a year truck driving job? Heck no, I'm not going to smoke marijuana." And then on the other hand, we're seeing a lot of drug abusers come to the state. We're seeing a lot of drug seekers and a huge influx of that. And we're seeing more violent crime. It was rare for us in Minot to see shootings and stabbings, and now it's, unfortunately, every month we have a few of both, it seems like. So things that we rarely saw, didn't really ever think of seeing, all of a sudden are happening. And the other thing I hear from some of my ambulance crews is they're not very comfortable anymore. They used to be able to go on any call and never feel threatened. And now they're going on calls where they don't feel very safe. And I don't mean hazardous material unsafe. I mean that someone could shoot at me. You know, I worked as a paramedic in Yakima, Washington in the mid-'80s. It was the most violent, Yakima County was the most violent county in the United States at that point in time, with all the heroin trafficking and illegal migrants. I left when they came around and started issuing bulletproof vests to fire and EMS. Thought, what the hell am I here for? And some of our people are starting to feel that way, that they're just not comfortable. And we've had EMS people quit that are volunteers because of it. So there's a lot of dynamics changing in our part of the state.
The thing that I have been aware of, and that is the gravity of the patients that are becoming to us. Ill-prepared, I would say, but you have to understand the circumstance. We have quite a few critical access hospitals out there. The doc is saying, I've got 3 patients here. I don't know which one's the worst one, but I'm sending you this one. And I just can't I can't do the full evaluation on this patient. We're just going to have to pack them into the back of the ambulance and send them because I'm just overwhelmed here. So that can happen. Mm-hmm. So now who gets the overwhelmed patient? The ambulance crew. Then they better be on their toes in terms of being able to assess those patients and reassess those patients during their transports, because some of those transports are 3 to 4 hours. Well, holy mackerel, that's scary. Not only that, we've had this problem with 2 of the critical access hospitals, most of which are more than 3 hours away, and that is that if they have a patient that has a cerebral bleed, meaning the hospital has a CT scanner, they can see that there's a bleed, but they're going to send them right now. Well, we don't have the ability to a neurosurgeon to coil an aneurysm. So as a consequence, we'd like for you to hold the patient until we can arrange to get a flight team from a place that does have a coiling physician who would be able to manage that patient. No, we're going to send that right now. I don't have the time to deal with this. I'm going to send it. You just deal with it. So that's what we do, because we understand their situation. That no, they don't have the time. They don't have the. Hey, I've got 1 nurse and I've got 3 patients here, and you're telling me I've got to hold this patient here, for what? So that they can die here? That's what they're thinking. So now the ambulance crew is the tag team.
So part of our responsibility might be then is to help educate them on priority setting and rapid decision making and how to, I don't want to say multitask, but how to work rapidly in a high volume situation. Because normally in the simulation, we're just doing 3 simulations at a time, and we debrief and really kind of a relaxed atmosphere. Maybe out on that side, we ought to add another dimension. I'm just thinking out loud here.
Yeah, and that's called triage. And actually, it is incorporated in a couple of courses, which are actually required by the state for all of these providers. But it may make sense. I mean, as we talked about, if you don't use it, you lose it. So maybe we do need to have some triage exercises for them. And I would agree with that. That probably makes sense, and that is, and justifiably so. 3 sick people actually overwhelm almost any of our facilities. I mean, I was in Colorado during the Columbine shootings, and we each got 3 people that needed to go to the OR immediately, and that tied up the hospitals all day. So I mean, when these smaller facilities get 3 people, I mean, it's a big deal.
They're not used to that. And part of it's not their training. I mean, as ER training, some of the scenarios in our oral boards is multi-patient situations, and it's to test your ability to do that triage, to do the most critical thing first for the right patient at the right time. So you might start out the scenario, you're dealing with a patient with cough, cold, little trouble breathing, and it's nurse comes in, oh, doctor, there's a patient that just showed up with chest pain. And you have to be able then to shift gears, get at least some orders going, and then that's, oh yeah, by the way, a trauma patient just rolled in, there's a knife sticking out of their chest. You have to know when to leave this patient, go to the next. And I think that's something our little facilities struggle with because they've never had to do it. Not that they maybe don't know how to triage, it's all of a sudden, and their resources are limited. There's one nurse, and a lot of times, or two at the most, if they call in help.
And the other thing is, a lot of the, if you go to them, the hospitals, they've only got 2 rooms for their ER. Got 2 rooms, one that's got equipped and one that's not.
Yeah.
And so you can understand why they want this one out. I'm done with this one. I can't do anything more. You're going to have to take them. You just take it. You arrange the transfers. I'm not going to do that because I'm busy taking care of these other 2 now.
And many times it's better that way. I know in our area we've had a couple of physicians say, well, why are we going to take this burn patient that's just going to get shipped out? It's, well, it was a blast injury. They need to be evaluated by the trauma surgeon before they're shipped out for other injuries. Or, you know what, laying in Botno with one doctor and one nurse and other patients coming in for 2 hours waiting for a plane, they're way better off to be waiting in our ER where we got, not unlimited resources, but a lot more resources than they do.
Exactly.
Well, I work, at the dispatch center in Minot, and I hear those doctors say that. Do you realize I'm the only one here? And they get put on hold, so, like you said, we don't walk their shoes, but, in their shoes, but.
You bet.
And there's not a code for the only doctor there.
Right.
We've got codes for everything else, but not the only doctor who's overwhelmed.
Well, I think the bottom line is you have to listen to what they're telling you. You can't put judgment on, when patients call, or doctors call me to send patients all the time, and they might say, well, how should I transport this patient? And I'll give them advice if they ask how I might think, but if they say, we need to fly this patient, and I'm thinking, why? Fly the patient. You're seeing the patient, you know what's going on, you have to do what you have to there.
So, just from the aspect of what we should, some things we might need to focus on the western end of the state. I mean, I've heard all of you kind of, mention things that, the western end would be a little different maybe than some of the eastern end or central end of the state. But I know a lot of paramedics, when they come out, they're taught, you're only going to have this patient 10 minutes. So bang, bang, bang. And then, but all of you were saying, you could have a brand new paramedic now that is basically being told, okay, I know you just came out of school, but now you're going to be a critical care paramedic.
That's right. That's exactly right.
So in terms of training, what do you guys think is our most important thing if we're just focusing on, that aspect of it to help them switch that mindset from, I'm going to give this because it's not going to affect them for me, because now they're going to think, what's it going to do 2 hours later?
I think some of what we said up here, they have to, there's obviously the ABCs, but I think then anticipating what could happen. And that's one of the big differences in our state. If you just drive around here, it's not that far to the next town as compared to you come out in the western side of North Dakota. It's, like Ben said, there's 3-hour transports out there. And so there are differences in that. So you're right on, and the time frame's different. And we're not going to be doing core training, but that's something that we can train some of the EMS services, and maybe that's something to talk about in scenarios that, hey, you've got a long transport, now into an hour of the transport, and you're not just given that one-time med, you're given repeat sedation for the intubated patient. How do you manage an intubated patient? It's not RSI, intubate, deliver to the hospital, I'm done. It's now all of a sudden you got a vented patient for 2 hours, and how are you going to keep them sedated, and what's the appropriate sedation? Are you paying attention to vital signs and giving the right drug at the right dose? Because you know what, you give a little bit too much of that drug, and their blood pressure all of a sudden tanks, and you have to deal with that. So there's a lot of areas that could be focuses on training, and maybe that's some of the services in the middle of nowhere now that have become paramedic paid services. Maybe that's training that they would want. And so we have to respond to what they think their needs are.
That's one of the scenarios that I'm hoping maybe will get incorporated in is, I'm a paramedic and I also work, I work in a small area and I have that long transport time, and I know the doctors get stressed and taxed because, you do get 3 patients and they panic, and it's like, I don't have enough nurses, and so they're like, here, throw out the ambulance, you deal.
You're the doctor. You're the right.
Yeah, no, you don't have resources, if you don't have the knowledge and the skill sometimes
Well,
to deal with this critical patient, so then you're on the road for an hour with somebody who
could die 10 minutes later, you know.
Even simple concepts, just a few years ago, we did a statewide assessment of the EMS system. And a survey went out to all ambulance services. And one of the things that just blew me away was one of the questions was, do you have online medical control? And the number of services that answered no to that, I couldn't figure, how can you not have online medical control? You all have online medical control. And what they're thinking is they're thinking in their own frame, box of their thought process that, I'm the Kenmare ambulance and our doctor's at home. Well, no, you can call my ER, you can call Ben's ER, any other of the big hospitals have doctors 24/7 and get medical control. So even training on how to obtain the correct advice at the right time and where to call. Should you be calling back to your doctor that's stressed in the little hospital, or should you be calling ahead and talking to the place where you're going with the patient?
And that happens.
Right.
To me, for the teaching moment, I think it'd be nice if we could run a scenario on the nurse or ER side and then move that patient to the ambulance side and maybe have that patient become more critical. So they, providers can kind of see the stress going on their paramedics.
Yeah, that's a good thought.
I think the takeaway message is you guys can't show up on site with one scenario fits all. We've got this abdominal pain scenario, and we're going to run this by everybody today. And I think that you're going to have, you're going to have to do some pre-planning for who the audience is. Because, even this issue about paramedics, David's right that we graduate paramedics, train them in an urban system, drop them into a rural environment with still relatively low volumes, and no mentorship.
Well, and I think
And so
one thing we got to remember is you won't find a more dedicated team that has something at stake, because it's their mother or it's their family, it's their friends. It's I worked in Beeson, and I'll never forget, this was a Friday night. 10 o'clock at night, a lady came up and said pregnant, she was bleeding, and we had that baby out in 25 minutes. We only had 2 people on call. When we had 5 in that OR, I don't know how we did, how you're going to call people, but they'll show up because they know that they got something to say, you know what I mean? And so that's something we have to tap into too, that Marjorie said that, they've got something at stake here where, Jeff may not see that gunshot. He won't know he's from Washington. He doesn't know the guy, But, they come in and they hand you their 2-year-old and say, here, fix this. Things like that I think we have to remember too, that they do really have a lot at stake.
Yeah.
And they want to learn. They're hungry.
I think whoever's doing your scheduling and your pre-planning, part of that process needs to include a inquiry as to what they feel their needs are. What are they looking for? What are their problem areas? And try to tailor that. And I know that's difficult, especially when you want to do a consistent training throughout the state and focus on certain objectives, but I think there's going to need to be a degree of personalization, especially if you want that to be effective and for them to be motivated to receive the training.
What's going to happen is we'll get the call, we'll get it all set up, and get it out to their team leader. And the goal is to have your team leader call out to the head nurse or the ambulance director and find out what their needs are. And then we'll have a batch of scenarios, and then you use those scenarios that are needed for them. We're going to start out with a smaller group of scenarios, because as maybe we've told you before, it takes a whole lot of work to develop and perfect a scenario to meet the standards and guidelines of the subspecialty areas. But once we do, then we get them rolled out, so we'll continuously get more and more. And as we mentioned before, I think maybe Jeff was here, but we will develop scenarios as you see the needs arise. So if we don't have one, and they say, boy, we're getting more and more calls for this kind of thing, they let us know, and then we'll develop it here, put it through our advisory committee, run it, refine, get it fine-tuned, load it up on there, and go out and do development with our crews, so you all know and teach it the same way. But yeah, every place is not going to have the same scenarios run for them.
I think another thing, John, I don't know if you've thought about doing this, I think this would be a good resource for this. When site visits happen for other reasons, like when we go to a trauma site visit to verify a hospital, look at equipment, we look at, charts and patients and process. Maybe SimND could become a resource, and maybe one of the questions that could be asked up front is, we develop a method of and a recommendation for equipment, for example. That our team, do you want our team to survey your ER, for example, for what equipment you have? And then our advisory group has come up with a core list of equipment recommendations to see does this match or not. A lot of places are going to say, yeah. And maybe some of the expertise then in the room can say, you got the right equipment, or hey, you guys don't have a backup airway if you consider getting, King Airways or LMAs or something like that. All you have is tubes and laryngoscopes. Or if you consider getting but I wouldn't walk into somebody and start criticizing their equipment, but maybe that's an offering that we could have is, our team's coming to do scenario training. Do you want them to spend 30 minutes to go over your equipment and your ER and make suggestions of things you might consider if you're going to be working on capital budget? We could do the same for ambulance services. And as an advisory group, we could pull together, and it's easy to come up with some of those core lists.
I see that as a great opportunity because there's not a single program that's going to hit every critical access hospital and every ambulance service other than CMFD.
Right.
That's not something we can do on day one when we roll out in June, but I really think...
Down the road, though, I think those are things that we could add as optional things that, hey, the truck is coming, here's other things that our group would offer you, is review of your equipment and
there probably is no better...
Review of your protocols for the way you do things.
No better venue to do that.
Right. And we would learn by that, and then it's shared knowledge that we might go to a little hospital and go, wow, no one else in the state's come up with this. This is fantastic.
Yeah, I think that's a great opportunity for us to advance. We're going to keep learning things like that.
It's a little off subject, but you guys are talking about you guys work with the state. Has there been money or resources to increase the amount of EMS staff in the state, especially out west?
There's huge.
Same with sheriff and firefighters.
There's bills going through now with funding, and some of them are in committee, a little chopped up and held up, but there's been huge efforts the last few legislative sessions to get money into EMS, and there has been money. What's the dollar amount last year was? What, Ken? That was 2.5, close to $3 million, and it's a huge jump this year. And that's going into in staffing and training. There's actually the state has been divided up into funding areas now. So not every ambulance individually gets that money for training and so forth, but there might be 2 or 3 ambulances in that funding area, and it's a way of trying to force collaboration amongst services. And and this is another way that if you're going to a small ambulance service that has 5 or 6 people, well, maybe it can be a collaborative effort between 2 or 3 services in the same area. And but there is some money going there, and every year the EMS Association is working hard to push that funding through.
And funding is increasing, but the issue still is one of, even if you have the money to hire someone, doesn't mean there's anybody
no one to hire.
I can tell you from my standpoint, almost all of my paramedics I've hired in the last 2 years have come from out of state, from national advertising. That there's not, you go to the job service right now, there's probably about 30 paramedic positions being advertised and unfilled. So
Who just wants to go there? Is that the issue?
Well, if you want a paramedic job in Williston, North Dakota, hey, that sounds good. Maybe you can go make $50,000 a year, but then you find out, well, wait a minute, the cheapest house here, the rent is $2,500, and geez, you walk into Walmart and go, well, the prices are twice as much here as they were at Walmart in Fargo. How can I afford to live here? We've had nursing, we've had over 100 nursing positions vacant in our hospital for a long time, and we bring people from all over the country will apply, and then they go, what's the cost of living in Minot? Well, Minot used to be one of the cheapest places in the country to live. Now it's one of the most expensive. And so they look at those factors. One, can you find a house? And if you do, what's it going to cost you? And what's it going to cost to live there? All of a sudden it's, working where I'm at, it's not that bad part-time. So.
Let's go with one more question, and we should wrap it up for the news.
I was just going to say, I only work 60 hours a pay period in Minneapolis at North Memorial. I'm going to have to work full-time to get part of what I was getting paid there.
Mm-hmm.
Pay is huge. $15 an hour difference.
Yeah. It's difficult. Our medical facilities in North Dakota get paid less than they do in the big cities, even though it costs us more to get staffing, and it's hard to keep up. It's hard to keep up, and I don't know if you have the same thing. I bet you do in Bismarck, but ground level staff, housekeepers, ward secretaries, it's impossible to keep those people. They'll take the job, you just get them trained in, and X oil company's paid this much for a secretary, so I'm gone. And I got that job. And, you know, with all these oil companies that moved into our area, as kind of being their head office for the region, and we can't keep those people anymore. They're just a continual revolving door. I've said for the last few years I don't learn the names of the ward secretaries in the ER anymore because they're not going to work here to come my next shift. I mean, it's that bad. It's that bad.
Yeah, but that's taking a toll on the actual facilities. I mean,
It
you're
is.
losing tons of money that way.
Yeah,
Because you're constantly worrying.
yeah.
I think we should wrap up, and I can smell the food when we get out, but just in summary, I think, you know, what we've learned is there's not just 5 important things that we need to go out and teach. There's multiple different things. We've got some good ideas at what to look for, ideas of how we as SimND can go out and approach these learners that we're going to be teaching, and how we need to be prepared for all the changes that are going to occur out there. And also know we have lots of resources, and the world is going to be wide open to us. SimND is basically a blank slate. We're going to end up finding we can do a lot more things than just teach with scenarios. So I'd like to thank you folks. Thank Ken and Jeff and Ben and Randy, who had to leave and go teach a statewide course. It's been wonderful having you here, and if there's more questions, you can bring them forward or maybe talk over lunch here, but you guys are welcome for lunch as well. Thank you very much.